Marion Sloan is a busy Sheffield GP with a special interest in women's health and gastroenterology. She's a member of the Sheffield CCG and a committee member of the Primary Care Society for Gastroenterology. And she is a hospital practitioner in endoscopy at Sheffield Teaching Hospitals. Marion.
Thank you, Nick. How can I follow that? Thank you. So I'm a GP. I've been a GP for quite a long time, GP in Sheffield. And I'm absolutely stunned to see so many people here on a Saturday afternoon. It's really wonderful. The health service is on its knees. The demand is so huge that we're going to have to engage patients in looking after their own health. So meetings like this is absolutely key, and this is the way forward for the whole of the NHS. So I think you're leaders, really, in a new pattern of care that we're going to see. So I'll just flick through some slides, but really it might be the interaction afterwards that may be the most interesting. So Sheffield, here we are in Sheffield. I don't know whether we're better at irritable bowel, but here we are, made in Sheffield. Who are these people also from Sheffield? Arctic Monkeys, very good. Okay, and Sean Bean, and yeah, you see, Sheffield's on the map. We're on the map. Okay, so what we're hoping with the NHS is that over time things improve. But do they consistently improve? And is change a good thing or a bad thing? So we've recently moved into big new premises, which have been fabulous to work in. So from an old house, which was pretty decrepit, we're now in this marvellous new health centre. And it is progress for us and a big change for us, because it's not just a doc and a nurse anymore. It is a big team of professionals. And I think if you speak to Nick, this is going to be the way forward for lots of diseases, including IBS. Or lots of conditions. It's not perhaps a disease. When we first moved in, this was the door opposite my room. And it amuses me every day when I look at it. And you think, what is a semi-ambulant WC? I thought, well, okay, I'll Google it. I'll find out. And that's what I got. You just have to laugh, don't you? You just have to laugh. So, in the olden days, it was just the doc, and he was usually male, grey-haired, fat, balding, not very tall, assisted ably by his practice nurse. And you probably saw the nurse once a year for your flu jab and the doc once a year for your medication review, perhaps. And that was it. But things have changed a lot, haven't they? So in the olden days, when you were poorly, you had a sore throat, you went to bed, you sent for the doctor came to see you at home, gave you all sorts of antibiotics probably. And then in a week or two, if you didn't improve, they'd send you to the hospital and you'd stop in there a couple of weeks. And then they'd send you convalescent to Skegness, to the miners' welfare, for another fortnight. Wow, how things have changed. I mean, that's when I first started as a GP. All those things are absolutely correct. Well, things are very different now, pared to the bone. And the problem with that system is if you got in it, you were locked in it, and there was this doctor dependence. You had to see the doctor and you had to go to hospital and things like that. So we're at a point now where we're going to have to do things differently. Things change with time. So we're now working with teams of professionals, and in our posh new surgery we have got a pain trainer, an exercise trainer, a smoking advisor, a lifestyle lady, another lady who helps you to go online, because going online isn't everybody's cup of tea, and some older individuals, they haven't a clue how to Google anything. So Maxine will sit down with them for half an hour and show them how to get online and how to get a laptop and maybe a tablet and get health information. The other very valuable person, and I could think the role of these medical professionals will improve and develop and widen, are the IAP people, the improving access to psychological therapies. And I can see a role here for a digestive disease practitioner. Now, if we ever got any funding, these people would be worth the weight in gold, because they would have all the skills, they'd have the knowledge of IBS, they'd have all the skills to enable people to minimize the symptoms and not to worry about the things that are happening to the body. So I think there's going to be some movement there. So basically, what we're looking at here is a team. So there's a team of medical professionals, but this is in conjunction with a motivated patient. So we're looking now. Are we coming? The next slide, please. At a different approach. No longer a pill for every ill. So things, you know, perhaps aren't quite what they seem. So if you have a treatment. That one coming, please. You see? Not necessarily what you thought. Now I'm going to introduce somebody else to you now. Who's this? Pamela Anderson, did I hear? It's the only Pam that I could find. Emphasis on Pam, P-A-M. Next slide, please. There you go. Patient activation measure. And this is the new buzzword. Ollie Hart, who's one of my partners in the practice, has just written this up in the Journal of General Practice this last month. There's evidence emerging that if you can get patients activated to look after their own condition. Now, Ollie's particularly interested in chronic long-term conditions like diabetes, osteoarthritis, things that are lifelong. But IBS is one of these conditions, and patients who are activated, interested, informed are easier to care for and are going to get much better outcomes, and in the long run this will save NHS money. So when you go to the doc, you've got to have done your homework, which is just exactly, Sabrina, what you were saying. If you can go in and write it down, some various points, you've got 10 minutes, and you know, in a lifetime, 10 minutes a couple of times a year is really not a lot to get out of your health professional what you want. And there we are, we can develop a partnership with professionals. Thank you.
Thank you very much, Marion, and thank you, Sabrina. I just wanted to ask you, Marion, do you think, I mean, looking forward to the future, I agree with everything you say, and I think something needs to be done. That's absolutely true. Do you think it would be feasible to seed the idea of having self-help groups in busy GP surgeries like you, self-help groups that are specifically for IBS, or they may be for unexplained disorders, including IBS? What is your thought about that? Is that a feasible?
Yes.
Is that feasible?
I mean, I think the answer is yes, and this is the way forward. And in our surgery, we're running coffee mornings, and this is assisted by the Healy Development Trust. And Maxine, the lady who does the digital inclusion, she's funded by them. It's part of the Sheffield City Council, and it's to do with keeping people well. So there's a forum there, and people come. It's roughly every 6 weeks, and we have a speaker from an expert patient, and it would be a good place to start a group like that. They're very well attended. We send out lots of invitations. They all go out by text, so they don't cost anything. And there are groups of people who are interested to come. So the answer is yes.
Yes, yes. And it sounds like you are doing that within your clinic. Is there a place for, you know, sort of active patients or patient activation? Active patients could come to you and say, hey, can I set up a...
Yeah. We have the premises. The meeting room is there. It's available. Yeah. There's a new concept that the PCT were talking about this week called neighbourhood involvement. So groups of GPs, 30 to 50,000 in size, will be grouping together, and that would provide a really good place to start. So within that neighbourhood, so there might be our general practice and the other people around Sheffield 8 area, all congregating. So within there would be IBS people, diabetes, you know, lots of disease-specific groups, if that was what people wanted to do.
Yes, a way forward.
Yeah.
Questions? Lots of, yes, there's one there. I can see lots of hands going up. There we go.
Yes, thank you both of you. That was a most interesting presentation. My only problem with it is if I went into my GP prepared, as you suggest, it would be greeted with derision rather than positivity.
Yes.
They're exceedingly patronising, and you know, how dare I?
Yes.
I didn't hear that last bit. Do it as, what did you say? You would be greeted with
derision. And how dare I?
Oh, I see.
Change your doc.
Yeah.
Change
Yeah, yeah.
Not so easy.
I know.
But
Yeah.
I would think there's a lot of people in that position.
Yeah.
I would love to be able to, I would love to have you as my GP,
Yeah.
to be able to go in and present the ideas and where
Yes.
I've come from, but it doesn't
Yes.
work.
Yes.
Sometimes if you book a double appointment, that might get you, because pressure of time is awful, and I think GPs do go to work in the morning intending to do a good job. They just get ground down because the pressure's huge. The workload is increased. I mean, I don't want to get on my soapbox, but that's the problem. That really is the difficulty, which is why allied professionals may be able to plug that gap. What GPs need to be able to do is exclude cancer, ulcerative colitis, celiac disease, this sort of stuff. And once that diagnosis is firm, then it's a long-term management thing, which is possibly more skillfully done by allied professionals.
But she's retired, overworked.
Yeah. Okay, I can see a couple of questions at the back there.
Thank you.
Hello, I am one of those allied professionals, and I'd like to know how to go about setting up something like this. I'm really pleased that this lady here, I've forgotten your name, has mentioned
Sabrina.
food, because the gut's prime function is to deal with food, and we don't seem to have touched on that enough, in my opinion. And not only the food, but all the other bacteria, viruses, and organisms that live in the gut. So the gentleman that was on before, who said that we have a limited amount of symptoms related to IBS, I think is very wrong. I think we have an unlimited amount of symptoms, because once the gut goes wrong, it affects every other organ in the body. So you can have anything from asthma, eczema, epilepsy, everything, joint problems, all sorts of things. So I'd like to know how to work with GPs to plug that gap. What would you suggest?
Depends a bit on what the symptoms are, but you have to exclude all the serious diseases first. But having done that, then either the IAP team or the dietitian team, there's dietitians in Sheffield with additional specialist training. Gillian is our main dietitian.
I'm not in Sheffield.
Not in Sheffield.
No.
IBS Network is a good resource. And team up with Nick, because I know one of your ambitions, Nick, is to get a new breed of professional, a digestive disease practitioner. And
I must say, I am quite shocked at what I've heard here today. I'm shocked at people standing up and saying we don't know about this, we don't know about that, because I think we know a lot more than has been suggested here today.
Yeah.
I mean, we know, for example, that your gut bacteria inoculation comes at birth. You know, we know that antibiotics hugely influence your gut bacteria in a detrimental way. None of that seems to be addressed in this forum. And you know, even small things like people starting with heartburn, taking Gaviscon, acids and things like that, it's going to have a dreadful effect on your digestive system all the way through. So none of that seems to have been addressed.
Okay, thank you.
And still not going to be addressed, I see.
Well, it's a big one. I think it has been addressed, to be fair. I think it has been, but next question, please.
Hello. I work in secondary care of the gastroenterology clinics, and I'm just wondering if the quality standard frameworks that have been published earlier on this year will create a good platform for the NHS Trust to build a business plan to provide non-medical facilitators for IBS patients that come to clinics and see gastroenterologists.
This has been a big problem in Sheffield. I know Sweeney Johal, who's one of the gastroenterologists at Northern General, would love to have a hypnotherapist attached to his team. He fought and got a clinical psychologist. The funding just isn't there at present. It just isn't there. Sheffield as a city has got to lose 15% of the income, and we're in this boat with the Sheffield City Council. So we're going to have to work smarter. Anything that's going to cost money has got to be taken from somewhere else. If we can reduce the number of referrals to hospital, and I'm very mindful of, Sabrina, what you were saying about you welcome referral to hospital, but every hospital referral costs £300 or £400. When you see your GP, it's about £70, something like that. So the more work we can keep in primary care, the better value we will get, and the NHS cake is going to spread a bit thinner. But that's the problem with trying to develop new things.
I think communication is really important, Marion. I must admit, I tend to spend my working time, my medical time, working as a psychotherapist, and I find it just is so useful to have that amount of time to listen to what a patient is saying and be able to respond. And I think you can deal with all of these issues, and you don't have to be, if you're working in this way, you don't have to be, and I'm often not, working psychotherapeutically or sitting there stroking my metaphorical beard like Freud or things like that. You're fielding questions on diet, on the bugs, on everything really, and trying to see it in a more holistic framework. At the same time, of course, of picking up on anything that might be worth, that needs to be investigated. That sounds serious. And I think the difficulty is that I speak to many GPs like yourself, and that they all say there's just not enough time. There's, 20 more patients waiting outside, and I've got to get through them in some way. So I've got to be very quick. And this is it's a little bit like this meeting, isn't it? Really, we've got about 15 minutes, and
can I just make a point?
Yeah.
Sorry.
Finding this time and time again, which is very, very frustrating, is what I've heard again today. It's a postcode lottery. And it depends where you live. You can't change your GP in the area that you live in just easily. Again, that's a problem. I think it depends on your the PCTs, the trust, and the council where you live. And unfortunately, it's rather depressing to come here and listen. In some things, I find depressing in what the doctor said, in that great if you live in your area, but exactly what the lady said at the back, if you don't, you're not getting the same fair treatment.
Yeah. So
and it's rather upsetting to think that there is treatment available and you can't get that access. And there is the money, obviously, but it's how it's been used in different areas.
Yeah. So what do you think about that, Marion?
Well, your area may spend more on something else. Everybody gets an equal allocation. It's a valid point that you're making, and this came up to the surface with the infertility services, where you could have IVF if you were 35 here, but in Rotherham, you could have it when you're 34, things like that. And it is inequitable. So if there is something specific, then take it to your MP. But in general, everywhere is given an equal allocation.
Can I just make a point as well? The point that I made about sort of NHS kind of referring you for counselling or third parties, because as we keep going over again and again today, doctors are busy people. They only have a certain amount of allocation. Sometimes it's just, sometimes it's just useful for the patient to be able to talk and feel that there's someone listening to them. Now, myself, this new surgery that I found, they've been brilliant. They've anything you ask them, they'll try to aid you and help you. And I was actually referred to, because I was going through a lot of stress at one point, for talking therapy or something. I didn't need it in the end, but the referral was there. So I think the point that I'm making is, aren't sort of more NHS systems working towards working with external organisations like that, where you can, because we spoke about it as well. So you're the central point that then kind of refers the patient to the correct course of action.
Yes.
So are most centres set up like that? Does it just depend on centre to centre?
Everybody will have access to IAPT, the Improving Access to Psychological Therapies team, and that's the talking therapy.
Yes.
Sorry, can we have the microphone there?
Waiting.
Sorry.
Golly.
Can't hear you.
Or psychology is different to IAPT.
Yeah, and even appointment with my GP 3 weeks not available.
Yeah.
Wow.
Yeah, so that's in Aberdeen in Scotland.
Is it? Yeah.
I think in the meantime, though, it's like really looking at what is already there. Like the IBS Network. If if you go on that site, you'll find so much help for maybe a short period of time. If you've got your GP's appointment in 3 weeks, take a look at what you can be addressing. Start, minimising things. and finding things that really are a problem to you. And then you can go with your pad and have already got some information about what's going on with your problems. Okay.
Question there. Oh, is that? Okay.
Hello, I'm from the Medical Advisory Service, and we've been associated with IBS, well, for many, many years, helping run the helpline for IBS sufferers. And we were actually founded, taking Sabrina's point, we were founded some years before IBS, in actual fact, on the premise of helping to have nurses train people how to talk to their doctors. Yeah. And that was one of the reasons why our founders put the charity together. And that service still exists. So our nurses are there if you wish to talk to them to help you plan your visit to the GP. And we've got more time, so it helps use that 10 minutes that Marion talked about.
Thank you, Chris.
Thank you, Chris.
Okay.
Hiya. I just wanted to say I work for the Improving Access to Psychological Therapies that you talked about, and I just thought maybe worth just telling people a little bit more about what it is. It's a national programme that was set up around 2008, and it's been rolled out nationwide. And I work in Norfolk, and I know in Norfolk and Suffolk that anyone registered at a GP in Norfolk and Suffolk can self-refer to the IAPT service. So if anyone was to look up IAPT on the internet, you should be able to find your local service. Where you live, there is a postcode. Look, that's a reality of healthcare, isn't it, today? And it's difficult to tolerate that, and it's also difficult to tolerate, I think, that different professions will do slightly different things, and they will always have different approaches. If you see a physio, one physio, they tell you something slightly different to another physio, but I think sometimes as patients it's really hard, and we can feel really angry and irritated about the fact that we don't always feel our needs are sort of being met. And in regards to this lady's comments as well, I think there was a paper, wasn't there? It takes about 25 years from a paper being published and finding something new for it to filter down into the mainstream and for GPs and other healthcare professionals to really understand these issues. And that's kind of the way it is, although I guess the internet kind of really helps with that now, and people are taking much more interest in their own health and managing it. So, yeah, but just to put you onto IAPT, really, in Norfolk and Suffolk, it's branded as the Wellbeing Service. So, different areas of the country, you'll probably find it's called something different, but essentially it'd be part of that programme. And some offer counselling, some offer cognitive behavioural therapy, a lot offer self-management groups or telephone support.
Okay, thank you. I wonder if I could just respond to that. I think there's been, a number of questions, comments that are really well received and taken, and that is about the fact that IBS can come across, or people talking about IBS can come across very negative. I must admit I don't see it that way. I think there is a real opportunity here, but it's an opportunity perhaps to see the condition in a slightly different way, that it doesn't fit terribly well into a medical model where you make a diagnosis, you apply the treatment and the patient gets better, satisfied doctor, satisfied patient. IBS is not like that. It's a highly individual condition, and it really does require, I think, each individual to understand what's really important to them and what instigates the system. For some, it may be antibiotics and change the microbiome. For others, it may be that they've gone through a period of trauma and it starts. For others, it could be an attack of gastroenteritis. But it does take time to try and match what might be the appropriate response to the patient. There isn't one size fits all at all. And I think what we're grappling with is how to match what is a very individual disease with a a medical service which does the best it can. In other words, it tries to make a diagnosis and apply an appropriate treatment. But one appropriate treatment to one patient is not going to be an appropriate treatment to another. And this is what we're struggling with. And hence, I think, self-help groups, understanding yourself, being informed, as Sabrina said, all of these things are really important. For the question, we've got a question back there. We'll come to you. Okay.
I just had a question. I've suffered with IBS myself, but I'm quite concerned about my son. So do you have any experience with paediatrics? When does it stop being, have some laxatives for your son? That's what happens to children. When do you start to think, well, maybe there might be a link here? I mean, I was brought up constantly on antibiotics, and personally, I do think that has a big impact. So I'm very wary now if he is prescribed antibiotics. Obviously, they're not as widely used now, but when should I start to, looking forward, we need to think about the next generations coming through. It seems to be more prevalent. There's a greater number of people here now than there would have been 5 years ago. But do you have any experience within paediatrics of IBS-type symptoms? When do you start to look a little bit further, but without putting them through unnecessary invasive tests?
Well, it's a very good question. You'd have to really start with a paediatric gastroenterologist, because with children, you don't want to go and miss something, because if they have got some malabsorption syndrome, they're not going to grow very well. So they need to exclude inflammatory bowel disease and celiac disease and all those things. Having done all that, then the reassurance that would bring is enormous. And you just then manage the symptoms. And it is more difficult in children because adults have insight and they can work with their therapist. Children, of course, different, and they might need play therapy or something alternative like that. The other thing, and the lady speaker at the back mentioned this, diet's absolutely key, and there's prebiotics and probiotics. So you've got to provide the earth for the bacteria to flourish within the bowel. Now, you're right about the antibiotics. We try really hard now not to give them, but they are given from time to time, and hopefully appropriately. So then you have to repopulate the bowel with the friendly bacteria that should be there in the correct proportions of all the different millions and millions of species. Next week, the Primary Care Society of Gastroenterology, which is one of my big interests, we've got a big meeting in London, and 2 or 3 of the speakers are all on about microbiota. And I think in the next 5 to 10 years, that's going to explode with information, and we'll be in a much stronger position to be able to give advice.
Yeah, there's a lot of research being done around that at the moment.
Well, thank you very much. I know there was a question here. I'm afraid we're out of time, but by all means, grab me or any of the other speakers after. Yeah. Can you? I think it's a really important point. Can you talk to me? Yeah. Okay. Yes. Thank you very much.
Thank you. Thank you.